morning, everyone. Welcome. Thank you for joining us for this learning series webinar, The Opiate Epidemic and the Impacts of Race, Part 2. This is the second webinar in this series addressing this important topic, and I thank you for joining us for this important conversation. Today's webinar is brought to you by the Partnership for a Drug Free New Jersey and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General. And I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to introduce our featured expert speakers with us today for this important conversation. Unfortunately, one of our planned speakers, Tanaga Malagarajo from the National Harm Reduction Coalition, was unable to join us. She's under the weather, so we will miss her expertise today. But we have with us a great panel of experts. So we have Dara Cass, Regional Director of Region 2, the U.S. Department of Health and Human Services. We have Bretta Jackman, a research scientist with New Jersey Department of Health. And we have Jared Hunter, a lead organizer with Salvation and Social Justice. So I want to thank all of our expert panelists for joining us today. And I will now turn the presentation over to Dr. Cass to kick us off.
Thank you so much, Angela, for that introduction. I'm really pleased to be here with all of you. I am thoroughly impressed with the attendance of this webinar already, and I think this is going to be a really fruitful conversation and one that's really, really meaningful to the people that we serve. So by way of introduction, my name is Dr. Dara Cass. I am the Regional Director for Region 2 at the Department of Health and Human Services. Region 2 covers New York, New Jersey, Puerto Rico, the U.S. Virgin Islands, and 8 tribal nations that exist within the borders of New York State. I am an emergency medicine doctor by training. I worked in the emergency departments in New York State, in New York City and New York State for almost 20 years before I was appointed by the president to take on this role. So the effect of opiate use disorders, the effect of, the prevention of drug use, but more importantly, the prevention, outreach, and the impact, the disproportionate impact on communities are so prevalent in the work that I had done as an emergency medicine physician. I really am appreciative of these conversations. So we're going to go to the first slide. I'm here just to kind of give a little bit of an overview of the issue of the intersection between race and opiate use disorders, but most importantly, the administration's view and role in helping to work with the states and local health agencies on this. So this is an overview of the opioid crisis in numbers from 2019, although they were updated in 2021. And none of this, I think, is new to any of us. You know, the numbers in this in 2019 were 70,000 people died from opioid use disorder in 2019. We know that number has increased over the past couple of years, certainly through the pandemic. We hit over 100,000 deaths, unfortunately, over the last year. We know that the impact is broad. We know that over 1 million people have had opioid use disorders in that past year. And again, that number is rising. These numbers are, like I said, are not new to a lot of us, but they are jarring. We see that this is a devastating disease that affects families and individuals, and we even need to go deeper into the layers by which this affects families. So let's go to the next slide. So so we know that there is a disproportionate impact of mortality for opioid use disorders, and this slide, which was taken from a paper that was published in 2021 called The Differences in Opiate Overdose Mortality Rates Amongst Middle-Aged Adults by Race, Ethnicity, and Sex from 1999 to 2018, does show that there are certain opiates that are that have higher mortality rates for non-Hispanic Black men specifically. And I wanted to show this first and foremost to show the disproportionate impact, especially on synthetic opiates. And what it looks like, but what is more interesting to me, although you can obviously see the disproportionate impact for men versus women, and then also on non-Hispanic males versus non-Hispanic Black men versus non-Hispanic white men. If you go to the next slide, you start to see the thing that I think that we're going to talk about a lot today, which is the trends, right? So this slide shows the overdose mortality involved in involving natural and semi-synthetic opiates from ages 45 to 64 in that same time period. And just to give you the context, those medications are things like morphine and codeine, oxycodone, and hydrocodone. But if you go to the next slide, you start to see a trajectory that is just completely overwhelming. This is actually for heroin use amongst the same age group of the same time frame. And you just see that line, which is non-Hispanic Black men specifically, just basically be almost exponential. Go to the next slide for a second. And again, here you see the slide that represents the use trends for synthetic opiates like fentanyl, fentanyl analogs, and tramadol. And again, the trajectory is just straight up. And so it really shows that when you go deeper into the data, it's not just that the overall impact is disproportionate, but that the trends are really alarming. Can we go to the next slide? And if you layer them on each other, this is what you see, which is another kind of continued trend upwards for the impact based on race. And let's go to the next one for a second. So what is the federal government doing, right? Well, first of all, in the 2022 budget, the president proposed $11.2 billion for the fiscal year, which is a 54% increase in the previous year's budget for 4 key areas, which are substance use prevention, treatment, harm reduction, and recovery support services. This administration is focusing dramatically on substance use disorders, mental health support, and other resources to make sure that we are really taking care of a whole of patient approach, and that we're making sure that we address issues that may have been under addressed in previous years. And the impact of opiate use disorders on people and their families, and the support of preventing that from happening, but also addressing patients that have substance use disorder, is really important to this administration. Let's go to the next slide. Okay, so the 4 key areas that are described in the impact are primary prevention, harm reduction, evidence-based treatment, and recovery support. And that really speaks to kind of the areas that we can affect people and really save their lives. And I think today we're going to talk a lot about primary prevention, but remember that it is an opportunity to every intersection of the engagement with the patient, whether it is in prevention of first use, whether it's in harm reduction for patients that have a substance use disorder, and that we want to make sure that they are engaging in less harmful behaviors if it means getting them enrolled in medication-assisted treatments and therapies, and making sure that they are enrolled safely and that they have regular follow-up, or also making sure they have all the other aspects of recovery support. One of the things that's in this article, which I find to be so overwhelming, is the number of people that leave incarceration, and 127 times more likely to overdose after you leave incarceration for first use of an opiate if you've been without it for a while. And that to me is just an overwhelming number that disproportionately affects Black Americans. And I think that we need to really make sure that we're doing everything we can at every intersection to affect people and to get to them where they are. So I think next slide is just the resources that they have on, so findtreatment.gov. There are increasing number of resources available at the federal government and on our websites through SAMHSA, which is the Substance Abuse and Mental Health Services Administration, which really is leading the way on supporting programs in communities and making sure that we have a way to support the work that you're all doing on the ground. So with that, I'm going to say thank you. Go to my next slide. And I am Dara Cass. If anyone out there wants to reach out to our office directly, it's dara.cass@hhs.gov. I'm going to hand it back to Angela. I think I was under my 12 minutes, and I will be excited to listen to everybody here and then speak at the end, just answering any questions.
Thanks so much, Dr. Cass. Yes, you were great on your time, and thanks for giving us that overview of not only where we are, but what the administration is planning and providing. So appreciate that. And just to note, last month's webinar focused on vulnerable populations, and we did speak specifically about incarcerated individuals and when the challenges they face upon release when it comes to the addiction crisis and the opioid crisis that we're facing. So thank you for bringing that up. Yeah, well, if there's any questions for Dr. Cass, please put them in the chat, and then we'll get them to her at the end of the presentation today. Our next presenter is Bretta Jackman. Bretta, I'll turn the presentation over to you now.
Hi, thank you. I may wind up chewing up a little bit of Dr. Cass's leftover time, so I'll try to be efficient as I go through. So good morning, everybody. I'm going to talk about the differential impact of fatal overdose among New Jersey populations, and that sounds really kind of esoteric, but you'll see. Oh, next slide. I forgot I'm not really fancy. So what's happening in the state of New Jersey? There's a lot of work, there's a lot of data, and there are a lot of people trying to get their hands around understanding what is going on with drug overdose in New Jersey. One way that we can tell the story of the overdose crisis is through the overdose fatality review teams. They look into the individual circumstances in fatal overdose and try to discover missed or unidentified opportunities for intervention or prevention in the future. We learn about emerging drugs in the environment through the amazing work of the New Jersey State Police and the Drug Monitoring Initiative. We use, in public health, we use them as kind of our early warning system. Their reports of what they find in the field often serve as an early warning for us to see, to make sure what we're looking for down the road in mortality data. And xylazine has been a really good example of how we've been able to find that and address it and figure our way around it. Other ways of looking at drug overdose in New Jersey is by location of fatal and non-fatal overdose. This is where we get hurt. This data analysis by location of injuries helps to really inform the efforts of EMS and law enforcement response, making sure we have enough naloxone to administer to people where they are. We can help staff up and supply emergency departments who are receiving and treating patients, and just making sure that we have resources in place to help people where they are. And then the last kind of axis that we look at data is by residents of victims of fatal overdose. And this is reflective of where we live, and not always where we die. By looking at residents information, we kind of can gain a little more insight into people's access and proximity to medical and mental health care, basically everything that they may or may not have access to: employment, transportation, education. And many recovery resources and services are based on the county that you live in, not the county that you overdose in if you survive. So it's really important to understand what's happening to residents as well as places where people get hurt. Next slide. So the next few slides are going to be from the Center for Health Statistics based on death certificate data. For the last 20 years, this is our, people in New Jersey are probably very familiar with graphs that look like this. We've always had kind of a historically higher than national average background rate of drug overdose, driven a lot by heroin overdoses. So kind of seeing increases in overdoses here in the state, we lagged behind the rest of the country in really seeing the impacts of prescription drug overdoses. It wasn't really until 2009, 2010, 11 that we started seeing prescription drugs as cause of overdose in our mortality data. And then, as you can see, in 2014 and 2015, that's the arrival of fentanyl widespread in our environment here. You can just see the fatal overdose rate just explodes and hits men. 70 to 75% of New Jersey drug overdose deaths each year are among males. And I noticed in the previous presentation, nationally, there was a little blip up in overdose deaths in 2006. in New Jersey, we also had a preview of what fentanyl could ravage a community with. We had an outbreak of fentanyl tainted heroin in a couple of urban areas, and it really was cause for alarm, and we got a handle on it at the time, but it was really just a preview for what we were going to experience now. Next slide. This is rates by age groups. Probably not surprising, younger people have been bearing the brunt of fatal overdose in New Jersey, the whole time, but have really been affected by the rise in fentanyl. We also see, though, kind of an alarming increase among 55 to 64-year-olds and 65 and over. The younger populations seem to maybe be declining or plateauing, but the older groups still look like they're climbing. So that's something that we want to keep an eye on. Next slide. And then this is our breakdown by race and ethnic groups. And we know that we have many more race and ethnic groups in New Jersey than what I'm displaying here, but I'm showing the ones that we have enough information each year to be able to calculate rates for. And in New Jersey, it's really kind of limited to these three for now. When we start to do like small area analysis, that's when we can get to other groups. But for now, we're just going to look at this broadly. These are statewide rates, and as you can see, all three of our main race and ethnic categories have increases in drug overdose related to fentanyl, but different from the white populations, which appear to have peaked in maybe 2018 and are declining somewhat, hopefully. The Black population and Hispanic population just continue to rise. Next slide. So, okay, so can you click again? Next slide. Okay, can you go back one? I'm sorry, there was supposed to be animation in here, but I think that we might have skipped it. So I apologize if this is a little bit busy, but hopefully you can follow it. This is data from NJ Suitors, which is the Center for Health Statistics CDC funded enhanced fatal overdose surveillance system. And basically we're capturing more information about the drugs and the circumstances surrounding fatal overdose than we can get just from a death certificate alone. So I wanted to show just being able to split out, here's the white overdose, and then here is fentanyl as a contributing factor to these fatal overdoses. So the dotted lines are opioid, all opioids, and the bold line is the contribution of fentanyl. And as you can see in the white population, we're seeing a decline in opioid involved overdose since 2018, but Hispanics and the Black population are continuing to rise. And fentanyl is a contributing factor in most of these overdose deaths. Next slide. So I just, that slide right there was a state level, broad look at overdose based on race and ethnicity. But as anybody who lives in New Jersey knows, like, we are not evenly dispersed. we are not, distributed throughout the state equally. So just looking at population data, 71% of New Jersey's Black populations live in just 7 counties. 72% of New Jersey's Hispanic populations live in 7 counties, not necessarily the same as the first 7. And 72% of the Asian population lives in just 6 counties. Again, not necessarily the same counties as the Black and Hispanic populations. Community is not just race and ethnicity, it's culture, religion, common experiences, the things that kind of tie people together. So I think that when we're starting to look at what's happening in different race and ethnic communities, we need to keep that it's a multi-factor analysis that we have to keep in mind. Next slide. This looks really busy, but what it really is a population map. This is data from the 2020 US Census, and it shows in a nutshell that counties that have high population density, Essex, Hudson, Union, Middlesex County, Mercer County, Bergen, they also are associated with high ethnic diversity. Whereas counties that have low population density, your Sussex, Warren, Hunterdon, Ocean, Atlantic, Cape May, Gloucester, and Salem, they are much more majority white. The one exception is Cumberland County, which is, it's rural by every other way that we think of rural, but it's also an agricultural economy that has large non-white populations and a small urban center. And next slide. Okay, so I just kind of grabbed information from 4 counties, just to kind of show that even though we're talking about, Black, white, and Hispanics, they're not behaving the same way from county to county. For example, as we see here in Essex County, the Black population has the highest opioid-involved overdose rates, but they've actually been declining in recent years. And, I don't know if that's going to last, but we can hope. Whereas the Hispanic and white populations, their rates of overdose have seemed to have leveled out in the last couple of years. Whereas if you look at Camden County and Atlantic County, you see, the rates of overdose among the white populations peaked maybe 2017, 2018, and now are starting to decline, whereas the rates of overdose among Black and Hispanics are continuing to rise, at least in Atlantic County. It looks like in excuse me, in Camden County, they may have leveled out as well, but it's hard to say. And for Ocean County, I'm kind of showing you this because there's not a high Black or Hispanic population in Ocean County to begin with. So their overdose rates are really driven by the white population. And overdose in Ocean County seems to have peaked in 2016, and it's kind of bouncing around, hopefully lowering ever since then. But the presence of fentanyl is ever present in all of these deaths. So hopefully we can continue with declining rates for everybody where we can. Next slide. And then, aside from opioid overdoses, we've been hearing a lot of concern about, there's a rise in cocaine involved deaths. There's a rise in methamphetamine involved deaths. So what's actually going on with them? And with Suter's data, because we have more detailed toxicology, we can look at like combinations of drugs. So when we're looking at cocaine involved deaths in New Jersey residents, you can see before fentanyl, it's kind of like a low background level almost. And then as soon as fentanyl hits the scene, that's when we start to see increases in cocaine involved overdose deaths, and fentanyl is present in these deaths. In methamphetamine involved overdose deaths, this is more affecting the white population at this point. Counts went from fewer than 10 in 2012 to we're looking at 120 methamphetamine involved overdose deaths among white New Jerseyans. But if you look at the dotted line, that's also fentanyl. So it's not just methamphetamine involved deaths, it's meth plus fentanyl. Fentanyl is like in everything. Benzodiazepine deaths on the lower left-hand side. This is actually more of an indicator of polysubstance abuse, because there's not many fatal overdoses in New Jersey that are benzodiazepine alone. You may see benzodiazepines and alcohol, but really what we were seeing with benzodiazepines was benzos plus heroin, benzos plus prescription opioids. And so what we've been seeing in recent years is, again, the trend in these deaths has also involved a lot of fentanyl, but it looks as though rates for these types of deaths seem to be declining across all race groups. So, fingers crossed that that's a trend that will continue into the future. And then this lower right-hand corner, we're talking about a lot of drugs, but alcohol is a drug too, and it often gets left out of these kinds of conversations. But alcohol is involved in nearly a quarter of all fatal overdoses in the state. And so this is just a little graphic to show overdose deaths that involve alcohol are seen among Black New Jerseyans more than whites or Hispanics. Next slide. Harkening back to our emerging issues and how grateful we are for the work that New Jersey State Police Office of Drug Monitoring and Analysis does. We in our mortality data, we found a little bit of xylazine. And, on our end, we weren't exactly sure what it was, but we started to look at what was in the DMI reports, and they had started to see xylazine in drugs seized on the street back in 2015. And, so looking at our data, we had one death with xylazine in 2016, and then we really didn't detect more until 2019 and 2020. And once we started looking for it in 2020 and 2021, we're starting to see it much more frequently in the environment. And it is across, we're seeing it across race and ethnicity. So xylazine presents a particular challenge because it can complicate an opioid overdose because it's not an opioid, so it doesn't respond to naloxone. And this is information that that EMS and treatment providers, like at the scene, can help in managing a patient while they're actively overdosing. Next slide. This is a very busy slide. There will not be a quiz, but I just kind of wanted to point out the location of injury does matter, even when we're talking about residence-based information. Because if you look at this, the headings here, these are the location types where people overdose. And what really stuck out was that 80% of overdoses over the last 10 years have occurred in people's homes or apartments, either their own home or the home of a friend or somebody that they know. And this holds true when you look at it by gender. It holds true when you look at it by race and ethnicity. We're seeing 82% of whites OD and die at home, or OD and make the hospital and die, but they're overdosing at home. So we were looking at, how do you address that? And then there's another category here, bystanders reported to be present. 14% of fatal overdoses that happened in a home also had one or more other people in the house or in the location with them. So, one prevention strategy based on this information could be really, really hammering to people. If you live with somebody or know somebody who is at risk for overdose, you need to be ready. You need to know how to use naloxone. You need to know who to call and how to get help, because you may be the person who can save their life. Next slide. This is the last one, I swear. So this is a good surveillance system helps us to ask better questions. And I know, like, going through building this presentation, I had more questions come up than I could possibly even think to answer. And I hope that you have some questions too. Things that I'm interested in particular are specific and emerging drug combinations and how they're distributed across populations. and looking at what was happening with 15 to 24-year-olds in 2016 through 2018. We want to look at sub-county patterns of fatal overdoses, communities that kind of act and behave and live together, but exist across municipal or county boundaries. We want to use Suter's data to explore further what happens in homes. We want to look at, are there generational or cohort effects that can be identified and targeted? And specifically, I'm looking at those 55 to 64-year-olds. And then what's the effect of the internet on those who are starting to experiment with drugs, and what brings new users to the drug environment? We've been talking about drug overdose for 20 years now, and to see that the burden of overdose is still hanging on people who are 24 to 25 to 34, 35 to 44. Like, these are still young people. So what brings them into this environment, and how can we address that? Next slide. And this is our contact information at the Center for Health Statistics, and references for the information that I cited. And I'll be happy to take any questions when we're done. Thank you very much. And sorry I went over.
Thanks, Bretta. That was a really comprehensive presentation, and I think the questions that you had on the previous slide are the things that you're still interested in finding out more about. Definitely piqued my interest as well. I think particularly to see why certain communities within counties or who are neighboring with each other have those patterns. So looking forward to the question and answer portion at the end of this presentation to get some more insight on that. But now I will turn the presentation over to Jared. Jared from Salvation and Social Justice, turning the presentation over to you.
Great, thanks, Angela. Yeah, I'll do my best to be as concise as possible, discussing Salvation and Social Justice's work, specifically around the drug war and the way that intersects with different racial communities and the work that we're doing to combat some of those issues here in New Jersey. So you can go to the next slide. And this is just a brief overview of the work that we do, guided by our vision and mission. So we are a Black faith-rooted organization that focuses on liberating public policy theologically, but also leaning into marginalized communities and helping them envision creating their own community-led solutions to a very structurally racist society. And we do that specifically through working with communities around harmful policies in our state and seeking to heal those communities through the creation of more equitable and just policies around, social, racial, economic justice issues. Next slide. And so our theory of change, like I mentioned, is Black faith rooted, starting out with a space that's very important that we call lament, right? Where folks have an opportunity to truly voice their impacts and give testimony to the racist systems that they normally engage with, and moving together as we build capacity and a different type of mindset to address those issues where the most impacted are identified, where the injustices really shape the demands of that community through public policy. And then at that point, being able to start to mobilize and organize resources and people to begin the healing process of dismantling these kind of racist and evil structures, leading ultimately to a point of liberation for that community. Next slide. So like I said, I'll do my best to be as concise as possible. There is much more comprehensive kind of information that I could provide on the war on drugs impact, particularly for Black and Brown folks in New Jersey. But a very quick understanding of how this all really started and where we're at now, right? So the timeline of drug criminalization starts, in the late 1880s with the opium panic, right? And we moved to cocaine and marijuana in the 1920s and 30s as a result of fears, fueled fears of, resentment toward Mexican immigrants and other people of color, the heroin panic, the official war on drugs that starts in the 1970s under President Nixon, declaring that drugs are quote unquote public enemy number one, kind of turbocharging that drug war in the mid 80s under the Reagan administration, really hammering down on the drug war policies and practices. And so as a result, we start to see a really big uptick around like 1988, where we see 134% increase of drug war arrests in 1980, between 1980 and 1989. And we move into the overdose crisis, kind of fueled by the opioid epidemic in the late 1990s up until the present. And this is where we start to see a shift, right, in the way that the war on drugs is viewed, not necessarily as a racist or a race-driven issue, but now it's a public health issue. And truly, we need to be really clear and transparent that, because it was just mentioned by the previous presenter that a lot of this was charged and fueled by an increase in white people facing an issue of overdose crisis that really sparked a need for the rest of the country to say, all right, well, now this is a really big issue, regardless of the fact that there's been 100 years of oppressive policy and practice toward Black and Brown communities where it wasn't as much of a concern, right? So that's kind of a quick timeline of understanding how we got to where we are and why we are where we are. A lot of this, we do have to be honest about the fact that this is very racially charged and focused, whether or not folks want to believe that, or that's a part of the public discourse currently. And so, as you move through how New Jersey is impacted specifically by the drug war, over the last 10 years, between 2010 and 2019, New Jersey has spent $11.6 billion in enforcing the drug war. We've seen increased drug war arrests between 1986 and 2019. We've seen those move from about 10% to well over 25. The drug possession arrests in New Jersey have increased, after the passing of comprehensive drug reform acts. Again, all of these policies that are perhaps some might say indirectly impacting Black and Brown communities that are inherently racist because of how much more they impact folks of color. And so broken down, when we look at that $11.6 billion over the last 10 years, $5.1 billion in New Jersey has been spent to make drug war arrests, just to arrest folks. 2.2 billion to actually carry out prosecutions, to prosecute folks for some type of drug war charge. And 4.3 of that 11.6 billion has gone to incarcerating people for drug war convictions. Obviously, this really doesn't even, that number doesn't even take into account the fullness thereof of the 11.6 billion because of significant expenses in the criminal legal system for drug war enforcement, like insurance for police departments if they're sued, health insurance and retirement benefits for employees of police, court, or corrections departments, and capital costs to maintain buildings and other infrastructure, right? So it's a very systemic and deep-rooted issue in the way that we spend money, public funds, to enforce the drug war rather than to focus on other types of public health services spending. And so in New Jersey, we actually, we very far exceed drug war investments and enforcing the drug war than we do on public health approaches to drug use, right? So in fact, if the war on drugs was kind of a standalone agency, it would actually have a budget of about 4.4 times that of the New Jersey Department of Environmental Protection. It would have an average, amount in their budget of at least $1.2 billion invested in just enforcement for a fiscal year. It would be exponentially greater than other places, you know, more than 500 times greater than investments in harm reduction programs, 40 times greater than homelessness prevention, 140 times greater than investment in community health services. So we spend incredible amounts of money enforcing the drug war when we know that intrinsically punishment rather than prevention and treatment does not work. And so we're really kind of throwing our money into a hole here based on a very racist and systemic issue around how folks use, possess, and sell drugs, and really thinking about what is the work then that needs to take place to reinvent that system for folks that use or are possessing drugs. And so you can go to the next slide and I'll talk a little bit about the work that SNSJ has been doing around that work. So one of my roles with SNSJ is to chair our Abolish the Drug War Coalition of New Jersey. And three of our main priorities as it relates to abolishing the drug war are decriminalization of all drugs in New Jersey, and an incredible shift in reinvesting in harm reduction services and reallocating resources specifically to communities most impacted by the drug war. And so we are currently in the process of developing a model bill around decriminalization with folks from the Drug Policy Alliance, folks from the New Jersey Harm Reduction Coalition, who I believe were to be represented on this panel today, working around syringe access, as well as opioid resettlement work, as well as the same in cannabis reinvestment. We also are working toward a community-led first response program called Make the Right Call, and 2 pilot programs have been launched, one actually in partnership with the Attorney General's office in Elizabeth, and another that we are lifting off the ground in Trenton alongside our Restorative Justice Hub that just recently launched, and working on reducing violence and mass incarceration of Black and brown folks, specifically in Trenton. And so next slide will be the final slide. This is just some of my contact information. I hope I kept that as concise as possible and kind of giving an overview of what this impact looks like and the work that we're doing, but excited to answer questions and keep the conversation going. Thank you.
Thanks, Jared. And thanks for the historical perspective and really outlining how, you know, we can all look at doing better or looking at the policies through a different lens. So appreciate your presentation. So I know we have some questions that have come into the chat. We have about 15 minutes, so we should be able to get to a good number of them. I'm going to go to Dr. Cass and then Jared, if you could jump in and after, and Bretta. But Dr. Cass, can you discuss harm reduction strategies that the administration is supporting, similar to what Jared was speaking about? If there are any strategies that the administration is highlighting, and how can attendees who are on with us today reduce the stigma surrounding harm reduction?
Thank you for that. So I actually don't want to overspeak. There was a harm reduction, the harm reduction report actually in October that was released by the administration, which actually spelled out a lot of the steps that the administration is taking to make sure that people who have opiate use disorders and substance use disorders actually are able to do it in a safer way. A lot of the ways that is enabled is things like fentanyl test strips or needle exchange programs, or making sure that people are engaged every time they, let's say, do a needle exchange program to open the door for possible medication assisted treatment therapy, making sure that there are programs that are supported under CCBHC models to make sure that medication assisted treatment is part of a wraparound approach to mental health and substance use disorder, which oftentimes is concomitant in patients, especially when you intersect other vulnerabilities like the LGBT community or minorities across the board. The administration really understands that stigmatization of any substance use disorder, specifically opiate use disorder, does not end up in treatment. It ends up in, outcomes that are things like increased mortality, increased criminalization. And so it's really important that we meet people where they are and that we consistently engage them without judgment and make sure that we are understanding that there are a lot of things we can do that reduce harm while keeping the door open for longer term treatment and recovery.
Thanks. And before Jared, you jump in, can I just ask a follow-up question on that? When we talk also about, I know your background is in an emergency room, doc, and when we talk about prevention at the time, you know, an opioid is prescribed, we talk about that in New Jersey a lot about, you know, conversations and necessary conversations that are mandated in our state, you know, to inform patients, you know, of alternatives. Can you talk about some of the alternatives that exist and maybe some of the obstacles that face patients who are from different communities, not having access, you know, to maybe physical therapy or other alternatives? Is that something that you can?
Sure. So you're talking about the barriers to enrollment in medication assisted therapy programs?
Well, that is one thing, but I was talking really about prevention or even alternatives at the time of alternatives to opioids at the time of first prescription,
Right.
but also access to medically assisted treatment once we get into that.
So,
No.
so I think a lot of this, and this as an emergency medicine doctor, I can certainly speak to the layers of education that we have had around first use, right? So a lot of the data shows that, and has showed for years now, that many people that are addicted to opiates start out with a prescription, right? For some sort of a semi-synthetic opiate, whether it's a like a Vicodin or a Percocet, and then that transitions to increase in use, and then obviously transition to illicit substances. And so it has been important within the medical community to educate physicians and other providers on how to treat pain appropriately, but to treat it in a way that is responsible for potential addiction and transition to, you know, especially to patients that have chronic pain disorders. I think that one of the, and there have been conversations about whether or not we've gone too far, right? Whether or not enough people get opiates if they need it. But I also think that one of the other things to recognize is making sure that every time somebody comes to an emergency department for a refill of a prescription, that we are checking either ISTOP or whatever the registry is, to make sure that they're not coming back for 5-day treatments over and over again, and that they're actually going to a longer term pain management plan that isn't always just short-term opiate prescriptions. And then again, once somebody is identified, and a lot of times self-identified as having a substance use disorder, specifically around opiates, that they're enrolled in a program immediately that allows them access. And there are conversations we're happening at the state level and with other states on electronic referral systems that allow us to get to treatment programs quicker, and really find all of the regional substance use disorder programs that can enroll people in things like buprenorphine and Suboxone and Sublocade, that really allow them to be empowered to move forward with hope and with self-confidence. And I think it's really important that we continue to grow those programs.
No, thank you. That's some great insight from your perspective. Appreciate that. Jared, did you have anything that you could add to the conversation? What can our attendees do to help break down that stigma about harm reduction?
Yeah, sure. You know, I just want to kind of highlight some important statistics here when we're talking about harm reduction, right? So there's no way to really kind of frighten or punish someone out of drug dependence or use, right? So harm reduction is really a much more effective approach, because its value neutral stance toward drug use focuses on really supporting individuals defining and achieving their own goals, which are grounded in a kind of well-being and quality of life. So the CDC has found that people who access harm reduction programs are 5 times more likely to enter treatment for their drug use than those without access to those programs. They're 3 times more likely to stop drug use, and they're 50 times less likely to contract certain diseases like HIV and hepatitis C. So there's a lot of misconception, first off, right, that harm reduction encourages or increases drug dependence or drug use. Whereas a lot of research and quality data has actually shown us the opposite, that these programs are extremely effective in reducing drug use, increasing drug treatment options, as well as reducing the myriad kind of symptomatic problems on a health and societal level that do come about through drug use, possession, and sale and distribution. One of the other things around when we're talking about harm reduction and kind of the mindset, right, where we start to discuss how do we reduce the stigma. Decriminalization, and I just want to be clear when I say this, is decriminalization of all drug use and possession, as well as drug sale and distribution, but we're talking about it below an equitably determined threshold, right? So we're not doing this with impunity, but currently in New Jersey, we use a quantity threshold where the amount of a substance that someone can possess for sale or distribution triggers a criminal penalty. However, an equitably determined quantity threshold is an amount essentially, large enough for either personal use and possession or the possibility of holding, selling, or supplying drugs to a network. So those equitable quantity thresholds reduce racial disparities. They allow law enforcement to focus on large-scale drug sale arrest rather than low-level ones, which again, overburden the amount that we spend in enforcing the drug war rather than in other public health services. And when we talk about reducing the stigma of around harm reduction services, we kind of need to be very straightforward in understanding that again, the data is available in learning that abstinence only requirements or the like do not provide the outcomes when we talk about drug use or possession, sale, or distribution that we thought that they would. They never have. And the opportunity to create new systems of care, this kind of holistic approach that really focuses on widespread harm reduction services is really an important one. And we have to be honest that a lot of this has been completely racially focused and triggering. And if we care, right, about the fact that folks who have constantly been marginalized and prosecuted and persecuted for decades and even centuries, if we care about the livelihoods of these folks and understanding that the policies we create continue to oppress them, then we need to educate ourselves, engage with those most impacted, and develop public policies and promote larger harm reduction programs and services that put the person at the center. One of the things that I do in kind of a practical level in reducing my own stigma and bias around drug use is when we talk about the phrase addict, right? We kind of label someone or identify them as only because of that one characteristic, that they are a drug user. And rather than telling myself that this person is an addict, the shifting the mindset and even the terminology that we use, that this is a person who actively uses drugs, not a drug addict, starts to reduce that stigma because you put the person first before you label them as only one thing, right? So it's a really important distinction for us to make is, they're not a heroin addict, but they're a person who actively uses heroin, puts the person at the center, and it starts to shift the mindset to say, this is a person first that deserves high quality of life, good public health care, access to a decent economic, society that cares about them. It's a really important but subtle distinction that I would encourage folks to consider the next time you interact with someone who's an active drug user and automatically let that stigma sink in. Stop yourself and put the person first. And I think that's one trick, right? It's a much longer marathon that we're running, not here a sprint, but that's one trick that I use or one practice that I use to distinguish and start to reduce the stigma around those who actively use drugs.
Oh, thanks, Jared, for that. And I will tell you that our April Learning Series webinar, we had a great presentation on language choice that addressed that very issue, and encourage anyone who's interested in further focus on that to visit the website knockoutday.drugfreenj.org and look at our previous webinars to further this, get additional information on language choice and how important it is, like you're saying, Jared, and how it's kind of one of the first steps that you can make in making those distinctions of the language that you choose. So thank you for that. Bretta, not sure if there's something that you can add to the conversation or wish to add about harm reduction and the stigma surrounding it.
Wait, the evaluation is public. Yeah, I mean, I think that from my perspective, and I'm not actively in like the harm reduction community, so I'm coming at it as like a data analyst, but to me, it kind of seems that we need more, not less. This is my opinion. And I think that, you know, and everything above, you know, an all the above approach is probably would probably be the most effective. Like, I think that we need to meet people where they are at whatever stage they're in, and, you know, help them face whatever it is that's affecting their lives. You know, even outside of drugs, like if you don't have a home, if you don't have a job, if you are facing discrimination in other places, then that just makes you know, also tackling an addiction issue that much harder. So yeah, I would,
yeah, absolutely.
say yes.
Looking, yeah, going to people or meeting people where they are, I think is so important, both literally and figuratively, right? When we talk about this issue and the different services, how you broke it down within the different communities and what's available and what's not. And I think that's very helpful. I know we're coming to the end of our time, and there's some questions that we weren't able to get to. We launched the program evaluation. So if anybody could take a moment and just give us some feedback on today's presentation. I'm just going to go back to our panelists with one last question. If there's one comment or point that you would like our attendees to leave today with from your presentation, one last thing for them to remember. Dr. Cass, we'll start with you. I think we may have lost Dr. Cass. Bretta, we'll go to you. Any last comments for the attendees?
I think that I would just say that when we're talking about you know, the population in New Jersey, it's really, you know, very local populations, and each population has their own particularities and strengths and challenges. And I think that in our state in particular, one size fits all solutions are very difficult. And I think that you know, I think that there are challenges across the board for all, you know, all race and ethnic categories, you know, related to access to care, language barriers, things like that. So my suggestion would be to think hyper local when you're trying to address you know, programs and things like that. And the other thing is, you can always contact us for data, and if we have it, our job at the Center for Health Statistics is to share it. So please contact us.
No, thank you, and thanks for that. It's good to know that accessing data from you would be you know, an easy step. So we'll be sure to share your contact information with our attendees. Jared, is there any last comment you'd like to leave with?
Sure. Well, I'd just like to thank everybody for attending and you know, offering the opportunity to share some of our work and our approaches to this really complex issue. One thing that I would encourage folks, especially those folks who are in advocacy or harm reduction spaces, really socially justice focused spaces, is to continually ask yourself who isn't in the room, most importantly, those who are impacted, right? So even with this panel, right, making sure that there are continued spaces for folks who are impacted by the war on drugs or other relevant topics to make sure that they're incorporated, that those voices aren't left outside of the room or at the table. And so it's a really important component of the work to make sure that, you know, those who are most, those closest to the problem, I believe, are closest to the solution. And so incorporating those folks who are closest to the problem into the solution-making process is the best and most sustainable way to really address some of these very complex issues. So thank you again for your time.
Thanks, Jared. And again, thanks to all of our panelists today and all of you in attendance. We're going to continue this conversation because it is so important and it really impacts all of the work that we do, and particularly looking at all of the data that Bretta shared with us. I think there's definitely work we can all do. So I want to thank you again for joining us. Thank our panelists. If there's a question that you had that we weren't able to address, please feel free to send us an email and we'll try to get that to our panelists to get you an answer. We'll be sending out an email to you tomorrow with a link to today's presentation slides, as well as a video of today's presentation. And there's information on your screen. We're going to be having a webinar focused specifically on fentanyl on Tuesday, June 28th. So we hope that you can join us for that presentation. I want to thank you all again for being with us, and I wish you well. Have a good day, everyone. Be well.